Okay, let's discuss airflow and airways. And the first thing that we're going to look at is the flow volume curve. On the y-axis we have flow, on the x-axis we have volume. In the top part of this graph we're going to have expiration, and in the bottom part we're going to have inspiration. So we're looking at the flow at the top part, and most of the time a lot of people just look at this top part here. So what we do is you inhale as much air as you can, so the total lung capacity, and then you exhale forcefully, okay? And you exhale forcefully and you reach a peak expiratory flow, typically at high lung volumes. And then you exhale, 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 exhale until you hit that lower volume where you can't exhale any more air. And that difference between the far end and where you finish exhaling is the residual volume. Now there's a couple of important points on this curve. You have a point right here, which is FEV1, okay? And that's the amount of air that you can forcefully expire or exhale in 1 second. So that's the forced expiratory volume in 1 second. We also have this FEV 25 to 75%, okay? And it's basically the 25% starts up here and the 75% exhaled. So that's the forced expiratory volume, 25 and 75% of that. And that's suggestive of narrowing of the small airways, and it's typically decreased in many respiratory diseases. Also, the spaces between these two ends, you have the forced vital capacity. Okay, so you have many, many different things on this flow volume curve. I want to point something out that's very important. On the x-axis, you can have lung volume decreasing in this direction. But it can also be presented as a volume, okay, where it will increase in that opposite direction. So it will basically increase in this direction, and typically you'll have 6 to 8 liters written on here, okay? So pay attention to that x-axis. The next thing that we look at is when we look at that flow volume curve, that expiratory phase of that flow volume curve, we're going to have an effort-dependent region, really important, and an effort-independent region. So the effort-dependent, if you blow harder, you're going to get a greater flow. Effort-independent, no matter how hard you exhale, you do not get any increase in flow. So effort-dependent, those occurs at greater lung volumes. It's due to velocity and force of your muscles. So velocity and force, how hard you're going to exhale. The elastic recoil of the lung, okay? And also if the airway is open or patent. The effort-independent region occurs at low lung volumes, and that is dependent on elastic recoil of the lung and airway resistance, and the equal pressure point, EPP, and also it relates to dynamic compression. Okay, and we'll talk about dynamic compression a little bit later. So we have the flow volume curve, and then we have the effort-dependent region and the effort-independent region. And importantly, for that effort-independent region, we have dynamic compression and equal pressure point playing a role there. So I want to get an important concept down, okay, that will help you understand the rest of this lecture. So what we have here is alveoli during inspiration and expiration. And what's really, really important to note that it's a pressure gradients, okay, that drive air into and out of the lungs or the alveoli. So when you're inspiring, the lungs pull on the alveoli. You have a negative pressure relative to the mouth, which is atmospheric or 0, and you're going to have air entering the lungs. On expiration, the alveolar pressures tend to get a little bit more positive, and then you're going to get air leaving the alveoli going out of the mouth. Okay, so it's really important to note that pressure gradients drive air into and out of the lungs, okay, or alveoli. Okay, let's get some nomenclature and some concepts down. So in white, we have the chest wall and diaphragm. Those tend to pull out. In red, we have the lungs, and they tend to have elastic recoil. So let me just write recoil, okay? That's the elastic recoil of the lung tends to pull the lung in. And what that does is the pulling of the lungs in and the thorax expanding creates that pleural pressure, which is a little bit negative, and it's in that pleural space. The second pressure that we pay attention to is the alveolar pressure, P big A, okay? And that's the pressure within the alveoli. Then we also have the pressure within the airways itself. So the airway pressure is PAW, and it's important to know that that airway pressure is different throughout the different parts of the airways. And then we have derived or calculated pressures. So we have the trans airway, which is across the airways itself, which is the airway pressure minus the pleural pressure. Then we have the transpulmonary pressure. Okay, so that's in the pulmonary areas of the lungs, primarily the alveoli. So you're taking the alveolar pressure minus the pleural pressure. So these are a little bit of the concepts that you should pay attention to. And this figure is also in your textbook. Okay, let's look at EPP, or equal pressure point. And we'll be moving from this area down across to the diseased. Okay, so let's first look at what happens with normal breathing. Okay, and what we have is the alveolar pressure is plus 10. Okay, and that's because the major contribution is by the elastic recoil, and the pleural pressure is negative. So the intrapleural pressure is negative. Okay, so the pressure gradient goes from the alveoli to the mouth, and the mouth is basically 0. Okay, and the air will be forced down that pressure gradient. And with a normal tidal expiration, we're not going to have an equal pressure point because the pleural pressure is subatmospheric. So the pleural pressure will not cause a collapse of the airways. So no collapse of airways. No EPP. So next, let's look at normal forced expiration. So you're forcing air out, okay? And I want to point out that these little circles, those are cartilage. So let's draw those cartilage on the upper airways in the diseased. Okay, so when we look at this one, what we can see is that the intrapleural pressure becomes positive when you're forcing all of that air out, okay? The pleural pressure plus 30, okay? The lungs are, and the muscles and diaphragm pushing really, really hard to compress the lungs, and you're going to get plus 30 pleural pressure. The alveolar pressure is going to be plus 40 because the pleural pressures are going to cause it to be plus 30, and then you add that elastic recoil. And what happens is that pressure gradient decreases to the mouth where it's 0, okay? And at a certain point, that airway pressure is going to be plus 30, which is going to be the same as the pleural pressure, okay? So airway pressure is equal to pleural pressure. And that's where the equal pressure point occurs, okay? So what we have in the normal forced expiration, the EPP is in cartilage-supported airways. And as you exhale more and more and more, and then slowly it moves down into the non-supported airways. And that's where you get the effort-independent breathing. So you eventually, at low volumes, you will get EPP. Okay, very, very low volumes. And you have the effort independent portion of that flow volume curve. With the diseased state, when you have the forced expiration, what happens is the EPP moves even into lower airways. And actually, this can even happen during normal tidal volume breathing, okay, because of the diseased state. So what happens here, for example, in emphysema, we lose that elastic recoil of the lungs, okay? So that elastic recoil, instead of being 10, is plus 2. Therefore, the alveolar pressure is plus 32. And you're going to have less of a gradient, okay, as you go towards the mouth, okay, which is 0. So you go from plus 32 to 0. And at a certain point, that EPP, equal pressure point, will be in the lower airways towards the alveoli, okay? And right above that point, you will have dynamic airway compression, okay? And that's basically where the airways get compressed. And if it's in the airways that are not supported by cartilage, you get the dynamic airway compression. And this is responsible for the effort-independent region of the flow volume loop, both in normals and in disease. But the problems with the disease state is that this effort-independent region will occur much earlier and much deeper inside the airways. So With the disease, more rapid pressure gradient decrease. The EPP moves upstream, okay, up the stream of the flow. Okay, so this is the airflow, so EPP moves upstream, okay, towards the alveoli, moves into smaller airways without cartilage. You get collapse of those airways, dynamic airway compression, and that occurs at lower lung volumes. You're going to increase the resistance, you're going to decrease that flow. So that dynamic airway compression basically results in that effort-independent region of that flow volume loop. Dynamic airway compression can occur in normal forced expiration and diseased expiration. So let's recap. Normal breathing, you do not have an equal pressure point because the pleural pressure does not become positive. When you have a forced expiration in the normals, the equal pressure point is supported in the cartilage, and then as you go to lower lung volumes, then that equal pressure point can move down and cause dynamic airway collapse. Okay, so on the low volumes, it can cause dynamic airway collapse. Okay. In the diseased, with forced expiration, you have lower alveolar pressures. For example, in emphysema, that equal pressure point is going to move lower down towards the alveoli, and it's going to occur earlier in the disease. Okay, and then you can have dynamic airway compression. So some people with emphysema, what they do is that they purse their lips while they breathe. And what happens is, this is pursed lips, right here. What happens is that creates a valve way up at the mouth. And let's say that this is plus 32, then this pressure will be plus 32 all the way up here, okay? And what it happens is you're increasing that airway pressure, so that airway pressure is increased. And you basically keep those airways open. So airways are open, okay, with the pursed lips. And some people with emphysema breathe that way, and that's just an adaptation to keep those airways open and prevent dynamic airway collapse. So the last thing I want to talk about with reference to that equal pressure point is with emphysema, you'll have a loss of elastic recoil, okay, that was discussed before, but also you have increased airway resistance because you have loss of radial traction, keeping those airways open. And we'll talk about that in later on in this lecture. Also in a disease such as when you have an airway obstruction, okay, you have a steep pressure gradient, and you can also have dynamic airway compression there. Okay, let's see how the flow volume curves are altered in different disease states. So we have the restrictive pulmonary diseases, where you have a restriction of air entering the lungs, or we have obstructive pulmonary diseases, where you obstruct air going out. The obstructive is shown on the yellow, where you have a left shift, and this restrictive is shown on the right, where you have a right shift and you have lower lung volumes. So the normal in the center, we have FEV1 over FVC is about 80%, forced expiratory volume in 1 second over forced vital capacity. In the obstructive disease, you have a scooped out shape, okay, of this region of the flow volume loop. You have an increased in TLC, FRC, RV. They can also appear normal depending on the severity of the disease. Then we have a decrease in the peak expiratory flow, and it decreases FEV 25 to 75%. In the restrictive, it has a more vertical shape. Okay? And what's important here is that both the FEV and FVC both decrease. Okay? So that means that your FEV to FVC ratio is increased or normal. Okay? So that's really, really important for the restrictive. Okay? So you have the FEV to FVC is increased or normal, and that is in contrast to that of the obstructive, where you have a decrease in the FEV to FVC ratio. So in the center, we have the normal. In the red, we have a right-shifted restrictive disease. On the yellow, we have obstructive, which is left-shifted. The obstructive has a scooped-out shape, can tend to be a little bit wider, and the restrictive tends to have a more vertical shape. So the last thing that we look at is airway resistance and how it changes with lung volume and airway generation number. So in this first graph, we have resistance on the Y and lung volume on the X, and you can see a dramatic decrease of resistance as you increase the lung volume. And what happens there is the airways are pulled open by radial traction. So as lungs expand, you have an increase in radial traction, and basically those smaller airways are pulled open. In the bottom part, we have the airway generation and how that affects resistance. So resistance is on the Y, the airway generation is on the X. And we have in the yellow line is that the resistance decreases as we go further down into the airway generation. So resistance is high in segmental bronchioles, lower in terminal bronchioles. Okay, why? That's because of the cross-sectional area. As you go further down into the lungs, the cross-sectional area of all those airways start to add up and become larger and larger and larger. So basically, you're going to have a larger cross-sectional area, you're going to have less resistance.